Welcome to the 8-Minute Rule podcast, where actual physical therapists share clinical pearls designed to create conversation around what's getting results in the clinic. No fluff, no Medicare stopwatch, only quality content. I am joined today with fellow Drew and fellow in training Mark. Next week will be Lucas's first episode, so you guys can get excited about that. But our goal here today is just to bring you some good clinical quality from a bunch of guys that are treating in the clinic and working to get success as well too. So if you have not seen episode 1 of posterior and lateral hip pain, please go back and take a look at that before this one. It's going to be really helpful to get some good subjective and objective communications there, looking as we're now working into treatment of those. So shout out as well to Andrew for providing comments on last episode as well too. That's really what we want to do, is continue to get some more feedback, and then hopefully get to a point where we're tackling some clinical situations that you guys are bringing up. So please feel free to dig in on teams and keep that communication going. So now what we're going to do, again, posterior lateral hip pain. We've already screened a few things out, and we've kind of veered them into a couple different categories. So we're going to start in specific categories in terms of what we're doing treatment-wise. And Drew, I'm going to shoot it over to you.
All right.
As we got our 8-minute countdown now.
And now we're starting. All right. So I was going to talk a little bit about the common presentation I see on that lateral hip pain when it's primarily coming from the lumbar spine. Most of the time, the most prevalent pattern that I typically will see is somebody who has some sort of like a lateral stenosis or an extension intolerant, where that's referring down into the posterolateral hip. And it can a lot of times look like maybe a glute tendinopathy or something like that, because when you go to stand on it, it can radiate that pain either because they're extending or maybe they're side bending because they have some weakness, and it just closes down and refers that pain there. My dad recently had this, and even he was like, yeah, my back doesn't hurt at all, but man, it just really hurts in my hip. So you can have that hip pain without back pain, even though it's coming from the back primarily. And so, in that presentation, uh, typically what I'll see is one or two things, is either when they're standing and they're walking, they're in the anterior pelvic tilt position. So they go into some extension, and every time they try and take a step, they are extending even more. So it starts aggravating or referring pain down there. Or the other one is if they have some weakness in their hips, they're getting that lateral hip drop, almost that Trendelenburg sign. And then they're closing down with like a lateral side bend, and it's just causing less space and aggravating that nerve that refers down into the hip. So the thing that obviously we're working on addressing the impairment. So if it's a kind of an extension-based one, they're having a lot of that pain when they go into extension. You can sometimes tease that out by doing like a standing lumbosacral extension and getting them into the anterior pelvic tilt, and that can refer symptoms down into the hip. So usually I'm working on trying to control that with some posterior pelvic tilt, some core motor control things. So starting on the table, maybe using some bands to give some resistance, and having them pull that down and maintaining a posterior pelvic tilt. That's one. And then I'm going to look a lot at hip mobility, trying to get them into more hip extension, because oftentimes that's fairly limited as well. So that way, as they're walking, standing, whatever it is, they can control their lumbar extension a little bit better and get into hip extension. Or if it's that more where they have that Trendelenburg sign and they're side bending, I'm going to work on creating a lot of stability through that hip and strengthening those hip abductors.
So Drew, for hip extension, since it's often bilateral, that they're having some limitations there, how are you spending the time to improve their hip extension?
Yeah, good question. So some of that depends on maybe where they're at. If it's someone who's highly irritable and they're having a lot of symptoms with any sort of that lumbar movement, I might start with something general and do just some long axis hip distraction to just kind of start calming things down. Because you want to just ease the symptoms as much as you can early on if it's in that like just high pain, high irritability patient. So I'm starting there, but then I'll sometimes get them into prone and do some hip PA mobilizations. Um, I know it can be a lot of time sometimes in the clinic. Early on, I'm doing that, but that's going to be a big focus on what I'm probably having them work on at home. And then depending on the patient, it can be anything in that almost that Thomas position, where you kind of focus on getting some of that core control at the same time, pushing that foot down to the floor and preventing that tilt, so they're not aggravating that over and over again. Or if it's somebody who can get down into the half kneeling position, I like doing that as well with a posterior pelvic tilt and driving forward. Um, using sometimes if you give resistance, use some resistant bands that can help to drive that hip forward and kick in the glutes as well. So you're getting some activation of in that posterior chain that can help drive that hip extension.
Yeah, I like that. I think big picture wise, it's super tempting to, oh, we got a posterior lateral hip pain. Let's stick some needles in it. Let's stick an elbow in there. And you know why that can be important for symptom relief early on. Obviously, you want to treat the root cause. You want to make sure that we're addressing that. And I really liked how you talked about the posterior tilt on the table. I've seen some people as well too that just that posterior pelvic tilt. You just see them compensating like crazy. That I've been able to do that same thing on the ball and kind of be able to, you could even do it with band resistance with a TheraBall where they're kind of using that to rock back and forth as well too. Definitely getting some good stuff out of that. Um, cool. Mark, what you got for us for posterior lateral hip pain? Maybe kind of in a little different bucket there.
Yeah, so I'll talk first about like soft tissue, like the tendon, the gluteal tendons there. Really, if you're dealing with something soft tissue, you may have to do a little bit of like joint work or surrounding area, especially early on if it's pretty irritated. But by and large, you're going to want to tackle it with active exercise loading of those muscles and tendons. So you're almost always safe to start with an isometric hold. That's usually a good place to start if you're ever worried about flaring somebody up. But if you do have somebody that's lower severity and irritability, don't miss the mark and just give them an isometric when they're already past the isometric phase and can handle more of the isotonic loading. And that can be, it can look a lot of different ways. It can be hip hikes. It can be band walks, monster walks. It could be a side plank or a side bridge, so to speak. It could be a lot of different things, but um, making sure that you're dosing your exercise, and that's really where that goes with the isometric or with the tendons is dosing your exercise appropriately, and making sure that they're following through on their own with those exercises. Um, as far as intra-articular goes, I like to start out potentially general depending on the patient, especially as higher severity or irritability, potentially going with something long axis like what Drew was saying. Just start it to initiate some movement. And then once their symptoms have calmed down a little bit or to their point where they can handle some more direct techniques, I usually try to target the directions that they're having the most limitation in or the most trouble with. So I don't remember who said it, but it said the magic happens at end range. So I try to take them, if they're limited in extension, I'll try to lift them up into a little bit of hip extension and do a P to A there. Or if they're having trouble with external rotation, I'll put them in a prone Faber and go P to A there. Rotations, I like to get the belt out and do some MWMs into internal or external rotation. And then as far as something that I think Lucas would appreciate, adding in some active assisted there, and some contract relax and some resisted while you're in that same position there because it'll segue really well into their home exercise as well.
Absolutely. That's good stuff. I know the timer's about to run out on us here for a second, but Mark, just one thought. You had mentioned glute isometrics starting out. Um, can you give an example position-wise how you're going to be able to target after that? Because I do think that's big, especially for these high irritability patients that you're really, really sold as glute tendinopathy. How do you get them to calm that down?
Yeah. So my preferred starting position would be standing, like having them push a ball into the wall essentially. But if it's higher severity irritability, that may still be too much, especially because a 30-second single leg stance is one of the kind of criteria to diagnose it.
Yeah.
So you may have to start supine and get a belt and loop it around their knees and have them just push out and against the belt there. That may be all they can tolerate to begin with. Until they can get into a standing and more functional position.
Yeah, I know it's over the 8 minute, but I love that thought and idea. But especially if it's high irritability, I'm also looking at how are they, um, you know, a lot of times you'll see people kind of hanging on one leg, they're sitting cross-legged. So making sure that you're addressing a lot of the things that may be aggravating this frequently, because you want to just really be able to calm that down. And then, yeah, I like to get in standing as quickly as possible too. So, the other thought, when you get from supine to standing, if you want to try and progress it quickly to that weight bearing, is it's like almost an isometric hip abduction, but you can keep the feet fairly wide so you don't get that compression with the adduction that usually aggravates it. So go a little bit wider than shoulder width, and just really try and put the feet out into the floor, and you can do an isometric hold right there. That is usually fairly tolerable early on for a lot of these patients.
Yeah. Good stuff. And obviously, you can throw that to a home program real easy. People can do that because really you're looking at high volume on these, right? I mean, this isn't you're going to do 3 sets of 10 once in the morning. I mean, this is something you're trying to get them doing a lot throughout the day. So they're getting used to loading those structures, working through some of that soreness early on too. So, well, good stuff. Nice little teaser here with Lucas. He'll be here next week for us. Appreciate you guys joining again. Please get some feedback for us in the Teams channel. We'd love to have it as we start working into our future episodes. So look forward to seeing you guys next week.